Hi there, and welcome to Dr. Mackama's textbook on plantar fasciitis. This is everything you ever wanted to know about plantar fasciitis. Hi, I'm Dr. Brad Mackama. I am a podiatrist, and this is coming in my 28th year of practicing, and mainly a sports medicine type podiatry practice. I say I have probably seen more plantar fasciitis than anyone. I practice in Key West in the land of sandals and barefoot, and yes, plenty of plantar fasciitis. This is designed as a textbook. This is designed as all-inclusive, start to finish for plantar fasciitis. The origin, the definition, the treatments, and you're going to learn it all. This is designed for doctors or medical students or that patient that just needs to know it all. Now, this will be broken into chapters and you could certainly skip ahead. My recommendation, however, is to learn it all. Listen to the whole thing, because we cannot treat something if we don't have it properly diagnosed. And we're going to start with that is, do you really have plantar fasciitis, or do you have one of those weird variants? Or do we need to focus more on one aspect of your plantar fasciitis than something else? This isn't your quick, here's your 5 tips and here you go. I'm sure at this point you've seen it all. This is comprehensive, and likely you're going to hear and see things that you have not heard or seen before. So bear with me and we'll start right now. Patient presentation. What does the typical patient come in with? We'll start with typical and also atypical. The typical patient comes in with, I have heel pain. First step in the morning, I have to get up. I have to hobble a little bit. It'll slowly loosen up, but I start out and I walk like an old man is typically what we hear. I can walk a little bit, loosen up, and it's not too bad. If I sit down a little bit at work, I get up from my chair, same thing. If at the couch in the evening, I sit, I get up, same thing. That stiffness after sitting, very common complaint from the patient, very classic. Also, no specific trauma. Also, recent gain in weight, recent increase in activity, many times recent gain in weight, so I went out and started walking or running and I just grabbed whatever shoes that I had. That is going to be a classic presentation for plantar fasciitis. Now, the abnormal one is if they're not telling you that exact scenario, and if there was trauma involved, if it was a fall from a height, if it was an impact of patients that were stomping their feet and they might not have thought much of it. A lot of it can be trauma related, and we'll get into those as far as differential diagnoses. But first is asking those questions to the patient of, has there been an increase in weight, increase in activity? Look at the type of shoes that they're wearing, because they may say, oh yeah, my shoes are great, but look at what they're wearing. Are they barefoot at home? Are they wearing a sandal with no support? Are they wearing one of these new flat, almost moccasin-like shoes, or one of the new cushion shoes that is allowing too much pronation? And they may think, hey, the advertisement said this is for plantar fasciitis. This was an arch support shoe. Do not take their word for it. Look at the shoe. Have them bring it in. Have them describe it or name the specific shoe. A lot of times they can just look on their phone and their Amazon account and say, oh, this is the shoe that I have. So don't take their word for it. Ask lots of questions to see that this is a classic plantar fasciitis, or is there some trauma? Could there be a stress fracture of the calcaneus? Could there be a fracture of the plantar calcaneal exostosis? We'll get into the differential diagnoses, but first, ask all of those questions. Athletes ask, was there increased mileage, change in shoes? How many miles do you wear your shoes specifically? Those are some of the more detailed questions to get into, is a change in pattern. And I'm not saying don't believe your patient, but question more detailed when they give you those questions about their shoes specifically, about their mileage. What do they do at home? One of the big take-home points for the patient at home is they discount everything that's at home. Like, I'm wearing my orthotics and my shoes at work and I'm there all day. And so I'm doing everything that I should be doing. Well, the questions with that are, well, show me your orthotic. Is this an over-the-counter just piece of foam that absolutely is not an orthotic? And a shoe that they said, well, I spent $150 in that shoe. It must be good. Well, it may have no support whatsoever. They go home and then they're barefoot and they say, well, how long are you barefoot at home for? Well, I'm just at home. And it's like, well, 4 or 5 hours of time barefoot at home. That really adds up. So the patient that thinks, hey, I'm doing everything I can for this, I don't know why I'm not better, actually had no support, improper shoe, and was barefoot at home. So don't take their word for it. Dive in a little bit closer and have proof of, show me the orthotic, show me the shoe. Tell me exactly what you do when you get up in the morning. Are you walking around for a couple of hours before you even put on your shoe or an arch support sandal? And if you're going to call it an arch support sandal, show me. All right, lots of questions, and here come some diagnoses. Another finding with plantar fasciitis pain, not by itself or separate, can be a plantar fibroma, which is a typical nodule, and by definition would be a fibrous tumor, but a benign fibrous tumor of the plantar fascia, typically in this area, typically about 1 centimeter in size, but I've seen them nearly the entire fascia. I've seen them in 10 or 20 multiples, but most commonly a nodule right in this particular area. And it may be painful, and someone may come in thinking they have plantar fasciitis when it's simply a firm nodule. Now also, if there is a plantar fibroma here, or here, multiple, that is going to tighten the fascia even more, making the fascia tighter and making fasciitis even more likely. So that is something to consider, and then discussing treatment modalities such as surgical excision of the fibroma, or what I've gone to almost exclusively is a compound verapamil to shrink the fibroma, and that's a whole nother topic. However, be aware, always palpate the entire fascia and look for any little nodules that are there. And here from the bottom you would see the nodule outside on the plantar aspect of the plantar fascia here, usually not extending up in this direction, or if I've removed them surgically, it's usually just here in and around the plantar fascia, not extending into the muscle belly deeper. One more aspect to look for on X-ray within the anatomy of the subtalar joint through here is a subtalar coalition. If there's any at-birth union between the subtalar joint, which might be seen by talar beaking up here, or abnormal surfaces through here, which would cause the foot to overpronate typically, and that may be a source of your rear foot pathology. It's just something else to discuss and address in the overall scheme of the biomechanics of plantar fasciitis. One more look at the anatomy, and in understanding the anatomy from this view and this view is asking the patient and finding out, and of course then compressing yourself, where is the pain? Is it here? Here? Classic, almost always in these areas. If there is pain up higher, they may have a spring ligament injury, and that may be mistaken for plantar fasciitis. They may have first metatarsal cuneiform pain here, or the supporting ligament here. Very similar in area, very similar in the pathology as part of excess pronation, but look closely, palpate closely, and palpate around the area in all of these spaces, not just at the fascia insertion. And no one said you can't have multiple issues, as they all are aggravated by excess pronation. Also, another anatomy tip, this is the classic spot of initial plantar fasciitis, but loosening this, doing all the proper treatments, this tight band here may be loosened, and then the pain may move centrally and eventually laterally as these areas loosen across, moving lateral, with the last being the lateral band then to loosen up. Also, keep in mind when you're asking the patient to roll a can, a PVC pipe, a rolling pin, a bottle, whatever it may be, on the bottom of the foot, make sure they're not just rolling here, but the entire length of the fascia through here, breaking up all of these adhesions. Here is another look at the plantar fascia or plantar fasciitis, inflammation in this area. Common questions are, do I have a heel spur? Is it the spur that hurts? And the spur is pointing in this direction here. You're not walking on a vertical spur, so the spur is fairly irrelevant. It just, think of it as a traction spur pulling this direction and an inflammation of the fascia here, and in some cases fasciitis throughout the fascia further distal. However, localized inflammation here associated around the spur, sure, or within the fascia, or without a spur at all. Just another look at the fascia as a support structure and seeing it extending out through the entire bottom of the foot. When we get to a can rolling type exercise, we don't want the patients just rolling here, but the entire length up to just proximal to the metatarsal heads, as this big structure will need to be massaged and to help break up scar tissue and adhesions for more mobility of the plantar fascia. So a wrap up for differential diagnosis. Other things to consider. First, pain in the bottom of the heel might simply be a callus, a wart, a foreign body. Take a close look at the heel. What someone describes as heel pain doesn't always mean plantar fasciitis. So here is another example of heel pain, and this actually is an extremely rare little accessory bone floating underneath the bottom of the calcaneus as another source of pain. So take a close look at that. When looking at the x-ray, of course, trauma, broken spur, stress fracture of the calcaneus. A lot of that's going to go back to the story as well. How did it begin? Was there some type of injury? Beyond that, other differential diagnoses are lower back, L4, L5, S1. They come down, terminate down in the foot, so be aware of radiculopathy or lower back issues. Also, systemic etiologies, systemic arthritis. Look and see that there's not other full body flare-ups happening and happen to be manifesting in the heel. So, big picture, but a lot of the answers lie with the patient. X-rays. Okay, so it's that all-important moment of the office visit in which you have your x-rays, because this patient, if they've done any research or talking to their friends, is convinced they have a heel spur. It's probably the only thing the general public knows about heel pain is a heel spur. So they're all convinced they have a spur, and they may have one, okay? But that's where the x-ray is going to come into play. I'm going to go through several examples of what to look for on the x-ray, some subtle signs, some obvious signs, but the x-ray is critical that there's a weight-bearing x-ray. We want to see what the position of the foot looks like in a weight-bearing structure, also how the joints are functioning. We want to look for, is there a subtalar coalition? Is there a falling mid-tarsal arch? Does it coordinate with excess pronation? Fracture, tumor, all kinds of things that we're going to look for in x-ray. I'm going to run through a bunch of examples of some things that you'll look for in standard and also non-standard. As again, I want to be all comprehensive in this. My first quick example is if there is a child or young teen with heel pain, very, very likely there's no chance they have plantar fasciitis, but they have Seaver's disease or an inflammation of the growth plate. You can see the tibial growth plate still open here, the posterior calcaneal growth plate open, and an inflammation of that being Seaver's disease, not plantar fasciitis. So I've got lots more examples that we'll run through now. Here is a closer look at this child with Seaver's disease. Again, here's the tibial growth plate, which is open. Here's the posterior calcaneal growth plate here, and very common where the Achilles tendon comes and attaches, it's pulling on the posterior calcaneus and creates an inflamed growth plate here. Usually a child that's growing quickly or in sports or gaining weight, and just they're doing an adult level type sport, and a little kitty growth plate can't handle that type of stress. Clearly no spur formation on the bottom or the back. This is all about the growth plate and not plantar fasciitis, but certainly your number one differential in any child with heel pain. So I've got lots more examples that we'll run through now. This patient is 80 years old and she presented with heel pain off and on for many years.
Most notable for her here is this very large plantar calcaneal exostosis here. This had some trauma in the past where the spur has broken off and calcified even further. She will end up with a massive plantar calcaneal exostosis. Also notable, she does have prominent bone on the plantar calcaneus here and a weaker fat pad here. There's not a lot of space between here and the bottom of the plate. She'll need accommodation to support this and take pressure off here. Again, heel cushion or even a horseshoe pad to remove that pressure. Posterior calcaneal exostosis as well, also leading to and explaining part of the tight Achilles tendon, chronic pulling here, tight plantar fascia pulling here at the insertion, so much so that it has broken and recalcified. The arch, as you may expect, has a decrease in the mid-tarsal arch here, also adding to the fact that, as you would guess, is going to need some orthotic arch support. Here's a good example of a relatively normal x-ray where there is no calcification here, no plantar calcaneal exostosis. The posterior calcaneal exostosis is not present either, so relatively normal here, normal contour of the bone, normal density of the bone. The calcaneal inclination angle here a little low, so you're thinking there may be a little bit of some overpronation and collapsing of the mid-tarsal arch, which we can see here where the arch is falling. Another example of needing some orthotic support, but has not advanced to forming a large spur. So a final summary of x-rays. Of course, we're going to look for the bone spur and explain the bone spur to the patient, or exostosis. Is there no bone spur? Does it say, this hasn't been happening for very long, or maybe we need to look at different diagnosis? Or is it a huge spur that says the patient may have been overweight, a runner, or just really overpronates and having that fascia pull for a very long time on the spur on the bottom? Again, the spur is not what's painful, but it does give an idea of how much traction, pressure, pulling the fascia has had over time. We look at the mid-tarsal arch, how much it's collapsing, has a lot of correlation to how much stress is being put on the plantar fascia and correlates a lot with how much the overpronation is present. So we're looking at a little bit of a biomechanical exam by looking at the x-ray, of course, corresponding to the patient's own foot type as well. Also, of course, looking for fractures in the spur itself, looking for fractures in the calcaneus itself or other areas. Subtalar coalition to indicate foot type. Also bone density, an obvious bone tumor, other things like that. And always getting an overall look at the soft tissue. Can you see some soft tissue density, soft tissue calcifications, some arterial calcifications? Get a thorough look at the whole foot on the x-ray, but of course address the all-important bone spur, which most lay people will come in thinking that's their diagnosis. So here is a unique x-ray, and for years and thousands of patients, I have said again and again, it is not the spur on your foot causing the pain. Typical, we'll see a posterior calcaneal exostosis here where the Achilles tendon attaches. We will very commonly see plantar calcaneal exostosis where the plantar fascia attaches. Almost never will we see a spur on the bottom of the heel. This, I had to tell this patient, yes, actually, this spur is causing your pain. She was older. She had very little fat pad on the bottom. You could actually feel the bony prominence. Her pain was right here. And in this extreme rare case, she actually had a spur that was causing some pain, and we needed to put a little horseshoe pad in the bottom of her shoe to take the pressure off this area. She had immediate relief of pain with that. But yes, this is one of those extreme rare cases where actually the spur was playing a role in the heel pain. When we talk about rare variants of heel pain or a differential to plantar fasciitis, we look at entrapment of the nerve on the bottom of the heel running right across here, in which the plantar fascia, and usually I see this in athletes, someone who is really overweight or someone like a marathoner, or someone who's been pounding and pounding, or with weak fat pad, where that nerve becomes vulnerable and wrapped in scar tissue and presents a little differently, keeping in mind that nerve pain is a burning sensation. So when the complaint is more burning pain, or when nothing else is working and there's a burning pain, or electrical pain, you've got to consider nerve entrapment. And so some steroid injections to try to break up some of the scar tissue. I've seen that work, and that's it. And it doesn't require anything more permanent. But when everything's been exhausted and that pain is doesn't fit the plantar fasciitis mold, is very focal right in this area, has the burning component, has that nerve-like component to it, then the last resort for that is to do an alcohol injection. There's some that would suggest a surgery to go in and release the nerve and do all these other aspects. I'm not a big fan of going in and cutting all of that tissue and releasing it apart, because again, you lose the strength and structure of the plantar fascia. I much prefer a focused, targeted alcohol injection into that area, 35% alcohol targeted right at where that nerve is and that nerve entrapment, and basically to destroy the nerve and stop the pain associated with the nerve entrapment. The injection is given very similar to your standard steroid injection for plantar fasciitis. Again, focusing and aiming right at where that nerve entrapment is. Often a little difficult on the initial injection based on how much scar tissue may be there, as that was the source of why it was entrapped in the first place. Very responsive. I've seen many patients responsive to this, and it usually presents as that difficult case where, hey, I'm doing everything right, this just isn't getting better. Definitely focus on nerve entrapment. Rare. Yes, it's rare. I wouldn't jump to that, but certainly keep it as a differential diagnosis, nerve entrapment.
Ultrasound or sonogram, this is not the therapy ultrasound, but this is the diagnostic ultrasound, where the detector here, you're going to place basically, and you always want to do the same thing, so all of your exams are the same. You'll put the cord on the proximal side, and right here you can scan, have the patient hold the foot in dorsiflexion. Here, use a little ultrasound gel, of course, and take your image basically right here, measuring, and you can scan across and you'll get yourself a good image. But basically you want to capture right in here the plantar calcaneus, the fascia insertion, and you're measuring, and you're available to see the fascia insertion area, the bottom of the calcaneus, and be able to take a measurement in this exact space. So with the ultrasound of the foot serves both as proof of the plantar fasciitis and a demonstration of how bad is it. So on the picture you will see, and I did my own foot and I measured it to be 5 millimeters. There's studies out there between 3 and 3.5 millimeter thickness of the plantar fascia insertion as normal. So my 5 millimeters would certainly say that the fibers are not nice and tight, standard 3 to 3.5 millimeter. They've got some scar tissue, they've expanded. So prone to have plantar fasciitis. Now, that doesn't mean that I have the plantar fasciitis, the inflammation. I currently don't have any pain. It's more of a fasciosis. So there is a damage, there's some scar tissue in the fascia itself. I've seen many marathon runners or very active patients or severe overpronators with a fascial thickness of a 10 millimeter. That's about the biggest I've ever seen, but they can be pain-free. They're just always at a larger risk because of the chronic damage to the fascia. So one, it's a diagnostic tool for the patient to say, yes, you have plantar fasciitis or fasciosis, let's say, And it proves to them, hey, there's a problem with the fascia. It's not a 3. Okay, as you look a little further distal, you'll see the fascia narrow out, and usually about 2 millimeters as it narrows out past the insertion area. So anything outside of that, you have fasciosis, you have damage. You have to look and say, hey, do you overpronate? What's causing this chronic damage to the fascia? So it leads into the discussion of the therapy, the support, all the rest of it. So it is a diagnostic tool, but it wakes up the patient to be able to see, hey, how much damage do I have? Okay, there's proof of this damage. Now let's move forward from there. Conversely, if someone's in severe pain and you go into the sonogram feeling like, wow, this is going to be a really big fascia on this scan, and it turns out to be normal, well, then you need to start looking at some of the other variants and say, okay, well, the fascia is pretty normal, pain is higher, I need to look at some alternative diagnoses, or an MRI, or see what else might be happening because the fascia was unexpectedly normal in that case. So use the diagnostic tool of ultrasound, one, confirming a diagnosis, but as a demonstration to the patient of the severity and how much work they're going to need to put in with regard to office therapy, home therapy, and continued support, whether it arch support, sandal support, or all of the above.
Different types of orthotics. An accommodative orthotic, mainly soft foam and cushion in the heel, it's going to flatten out in the arch. Not a whole lot of support. The idea being we don't want the foot rolling in this fashion. This way we want support. A prefabricated over-the-counter orthotic that you might find online might have some cushion, may have some plastic, but very thin, inexpensive plastic, and it's going to hold you up if you don't weigh very much, but it's going to flatten out quite a bit. It might have a decent little cushion in the heel and make you feel comfortable. Maybe it's good for one pair of shoes, but certainly not enough to control motion, and certainly not going to last a long time. Or if a heavier patient, definitely not going to hold you up. Here's a prefabricated orthotic that we have online and in the office, and you're going to see quite a bit more support there. Posted on the bottom, little cutout cushion here in the heel, so comfortable here, but definitely more support there. Custom orthotic, and this is my own orthotic. Again, going to hug the foot a little bit better. You can have it full length or this length right here. This is a graphite carbon fiber underneath here, and again, this is a rigid version. We can do semi-rigid as well, where this will flex more. So if you need maximum support, you're going to go with this. If you want it to be custom to the foot, let me show you on my own foot. You can see when I put weight down, there's this overpronation with the knee rolling in, and we want to stop that motion. Solid, rigid. You can see my knee staying in this straight line as opposed to the rolling in position with overpronation. So again, maximum support there. Also, the contour of a custom orthotic is going to fit the foot exact, and that's the benefit of a custom orthotic. So, final wrap up on orthotics. Number one, orthotics, critical. Absolutely have to have an orthotic and proper shoe to stop the overpronation as the absolute major underlying cause in the plantar fasciitis and the major step in why it's going to get better. So critical, must have orthotic support. It's more a question of, are you going to have a prefabricated orthotic or a custom orthotic? Not, do I need one at all? So that's critical right there, and that the patient understands the benefits of a prefabricated versus a custom orthotic as far as, do you need it hugging up against the foot? Do you need a more rigid material? Do you need to have a real specific biomechanical evaluation and adaptation to the foot? Or is it a lighter weight patient? Generic type orthotic would do fine because it's not major overpronation. They just need a little help in the excess pronation process. Or if someone's just not getting better and they're doing everything right, but they have a prefab orthotic, says, hey, we need to step up and get something more custom that's exact, 100% arch support, and maybe a more rigid material because functionally that fascia and that foot need some help, and it may be the material, the thickness, the stiffness of whether it's a plastic or carbon fiber type material being stronger. But the number one thing with orthotic summary is you have to have it. Hi there, and welcome to the chapter on shoes in the textbook of plantar fasciitis. So we're going to go over all of these shoes. Now, the key statement is just because you have an orthotic arch support, that does not fix your shoe. That does not mean you can wear any shoe. So number one, an orthotic does not fix a shoe. You still need a stability shoe, a support shoe. Also, if you have a stability shoe or a support shoe, it does not mean you do not need an orthotic. So you still need the orthotic, you still need the supportive shoe so that your fascia is not flattening, your foot's not pronating, you have maximum support. So the orthotic and proper shoe are needed. Common misconception is that you can have one or the other. Also, this is 24/7. All day long, every step needs maximum support. So I'm going to roll through this quickly, but I'm going to give you lots of examples. And thank you to my daughter of giving me some samples of good and bad shoes to wear. Okay, here we go. We're going to start with some sandals. Sandals not just for summertime or just here in Key West, but a lot of patients say, hey, when I'm at home, I'm barefoot. I'm home, I take my shoes off. Well, there's still gravity at home, so we need support. So even if at home is something, even a sandal, it should be an arch support sandal. So let me go through a couple. First, a bad example of a standard flip-flop that's too flexible and bendy. Now, if you don't weigh much and there's a little bit of an arch here, you could get away with that. But usually if it's a soft foam or soft rubber, not supportive enough. So here's your test, not enough. Now, a little bit on the dressier side is a bionic sandal with an arch in it, and again, a much more firm material and a raised heel. We'll get into this a little more also. The raised heel does recreate the arch, so I'm good with that. And here's your test, is that twisting like this, and if it's stiff and rigid and an arch, wear it. Wear it for a sandal, wear it for dress. This you can get away with. Remember, a little bit of a heel helps the arch better than being flat. Got to throw a little joke in there. Little bit of a heel. Little bit. Too much. Dangerous. Too high. Unstable. Yes, that's my daughter's shoe. She's allowed to walk about 10 feet in this. This would make more sense here. Low heel does recreate the arch. So if you have to wear a little heel, get a little dressier, go with something along these lines right here. What not to wear? Everyone's seen these. Everyone may have had a pair of these. That is not support. You can put an orthotic in here, your foot's still going to tip over, still going to have a problem. Need the maximum support in the shoe. We want to look for it built up here, raised heel. This has none of those things. There's your test. That's a failed test. So still on the basketball shoe line, Nike Air Force, good, stiff. Absolutely. Put an orthotic in there. I don't have a problem with that. Adidas, similar concept. Basketball, stiff, little bit softer, but okay. Kids should tie their shoes. Kids nowadays don't tie them, as you can see. Tied shoe with an orthotic. I am fine with that shoe right there. Weightlifting shoe, Nike Metcon, reinforced heel. Stiff in the back. Good choice for a weightlifting shoe, Nike Metcon. Running shoe, Asics Kayano, excellent. Built up in through here, wide base. Again, there's that stiffness to stop the overpronation. This is actually my current running shoe. Went running in this yesterday. Again, there's the buildup in there. This is the Kayano number 32. Yes, if you're watching this years from now, this will seem like an old shoe, but same concept. It can have the foam, it can have the cushion, but it can't collapse. And we talked about that in some of the other ones, but too big of a foam, too soft of a foam, the shoes aren't going to last. So you want to make sure there is some stiffness to it, and that after a couple months, that stiffness remains. After 200 miles, 40% of the cushion is gone in running shoes. And specifically, if you're not running, you shouldn't be wearing running shoes. Running shoes are not a good daily shoe. They don't last long enough. They're trying to be for lightweight, fast running. They're not really designed for daily use. So I would not recommend a running shoe for daily use. Back to a couple sandals. A Birkenstock would be a good supportive cork-based shoe. If there's a fake Birkenstock that's too soft, no support, no good. Vionic sandal, here's one of my own. Again, the arch is going to be a little more firm, the shoe a little stiff, a little more firm. That's okay for a daily at-home shoe, Vionic sandal. Another popular one, Uggs. Not the worst as far as stability goes, but pretty flat, so it's not really going to recreate the arch. Put an orthotic in that, a little bit casual, I'd be okay with it. Maybe not the first choice, but again, cold weather, casual shoe with an orthotic, I could be okay with that. Certainly as a house shoe or short term. Again, same thing here, a little bit of stability. Like to see a little more of a raised heel would help there as well. If we're on the lines of boots, again, here's a Columbia hiking boot. Any of the outdoor hiking tread is going to be real good for support. Some moderate to good stiffness here, and this way, this plus an orthotic, absolutely I'm okay with that. Here's a Nike all condition gear. This is mine, so of course it's going to be super stiff, but comfortable. I could wear this all day long with an orthotic. That's a Nike ACG boot. My absolute favorite, Danner hiking boot. This is rock solid, but comfortable. This plus an orthotic, your fascia is not doing any work whatsoever all day long in this. That is stiff, that is support. If you don't want your fascia to have any problems or any issues, wear that. Also, a hiking boot can be worn as a work boot. I recommend this a lot for my mail delivery, package delivery service patients. Along the lines of Nike, Air Max has some better support than most of the other Nike running shoes. And again, there's your test. That's about your max. You don't really want to roll more than that. And stiffness this way and this way, not bad. That's a DN Air Max. Another shoe I wear often to work, basketball shoe. A lot of the Jordan line are pretty stiff and supportive in through here. And again, stiff in those directions right there. Nice wide base as well. Dress shoe, my own. Again, a little bit stiffer. Not going to wear it a long time, but a little more stiffness with that. And again, you want to look for just the stiffer base to the shoe, like this. Not for long-term use, but you don't want to roll it up and fold into a ball. Got to have some stiffness with that, and of course, the orthotic inside the shoe. Anytime, I always recommend to the patients, bring in your shoes. And yes, I have patients, they bring in 20, 30, 40, 50 pairs of shoes. They'll bring them all in. Also recommend they bring in one. You don't necessarily need to see left and right if you're just talking about the support of the shoe. If you're looking at wear pattern, yes, of course, bring in the left and the right. You want to be able to tell the patient, good, bad, good, bad. And I tell those patients with those difficult cases of plantar fasciitis that you're not going to get better until you get up in the morning. First step to going to bed is maximum support with an orthotic all day long. And my best suggestion is that when you open the closet and look for a shoe, you only have choices that are wonderful supportive shoes. If there's a couple bad options, you may use those. So you have to go a little bit strict and extreme in the beginning, but That's what it's going to take to get it better. Maximum support. Nightsplints. Very important portion of treating plantar fasciitis. Nightsplint might not be the best word for these because if someone can't sleep with it at night, they're not comfortable with it, they just say, well, I can't wear my night splint, and they don't use it at all. Sitting, watching TV, while reading, while at work, anytime sitting, and you can have that foot held at a 90-degree level, a passive stretch, stretching the fascia, stretching the Achilles in a passive form rather than the foot hanging down the entire time, hugely important is that passive stretch. And the stretch can also be made more active as well. Now, trying to sleep with your foot cranked back like this, yes, that may not be comfortable, but if you're watching TV for a half hour and you can crank it up, have a really nice stretch, that's tremendous. That's absolutely critical for this. So Nightsplint, yes, is the typical name for it, but we just called it a day splint. Might get some more use from it. In either case, encourage patients always to use the splint anytime when at rest and as much as possible. What patients will typically say is, wow, I wore that splint and I woke up the next morning and I could stand for the very first time ever. And they'll be a little shocked, say, hey, that thing really worked. As if we didn't know that already. But it does take that self-awareness to use it the first time to really find out how much it works by just avoiding the plantar flexion of the foot while at rest. So critical with that. A couple different versions. One, a dorsal night splint going on the dorsal side of the foot. A couple quick, easy straps to slide on, toes in there, strap in the ankle around there. More comfortable, it's dorsal, doesn't really adjust. There's some other models that'll have a strap across here so you could dorsiflex it a little bit more, but definitely the more comfortable option. And if they had to get up and take a couple of steps, they could put a little weight bearing. None of these are for weight bearing. Make sure that's clear to the patients. None of them are really for weight bearing, but this is one you could attempt to stand up in because you can feel the ground with your heel. I would definitely not advise it in this version here, even though they'll put a little tread on the bottom, not really designed to walk in. Little clips that you can adjust all the way down the foot here. Obviously the foot's going to sit right inside like this. The difference and the importance here is this is a little bigger, bulkier, but the important part of the side straps will adjust and you can crank that foot up a little bit tighter. They also have a little wedge. A little wedge can go in here for an added stretch of the toes to stretch that distal portion of the fascia a little bit extra. I tend to use the dorsal splint for someone who just absolutely concerned about comfort or ability to put it on and have this as the easier product to use. Definitely more compliance with this as it tends to be a little more comfortable, a little more padded. That type A personality that says, hey, give me the best one. Give me the thing that's going to work the best and the fastest and that's going to sit down, or someone that's going to wear it at their desk or watching TV and they really want to crank it back a little bit, then the posterior splint is a better option for that. Best option, both. So it's utilized the most and whatever works best for the patient. Night splint, critical piece. In addition to the stretching, one tip on this is if there's pain first step in the morning, the night splint is still needed. Question comes up all the time, how long do I use it? When that morning pain, that first step is gone, then try it a night or two without the splint, try a night or two with it, and see what that difference is. One more variant of a night splint that you might encounter or your patients might encounter is a sock. And it's literally a sock with a string attached. Then they put the sock on, the string attaches to pull the foot up. A cheap, easy version. I'm not a fan of it from the standpoint of it doesn't directly pull the foot up. It takes sort of a path of least resistance. And I think you can imagine here, if that's not perfectly applied, that the foot could rotate. Just another look at that and where the pitfalls for this type of product could be. And I see a lot of patients will have some tendonitis, either medial or lateral from it. When they pull up, a lot of times there's a twisting of the foot, especially if they're sleeping and don't really have control over what's happening with that sock. So yes, under a controlled circumstance, if it's just being pulled up, if the only thing they have, it's the only thing that's creating a passive stretch, okay, fine. But when it comes down to it, I don't typically recommend it. The other splints I absolutely recommend more than the sock. Just want you to be aware of another product that's certainly out there and likely a much cheaper product that the patient may have already. Just watch for the rotation inversion or eversion that could create some other issues, if not an absolute perfect dorsiflexion with the sock. I'm in pain and I need to get better now. Patients ask, what else can I do? What more can I do? I heard the protocol, I understand what I have to do to heal this, but what else can I do? What more can I do? I've got to get back to work. I've got to get back to my family. I've got to get back to the gym. I need to heal now. What more can I do? You can do the laser. You're going to have your protocol. You're going to have your treatment plan. But what more you can do is stimulate your cells. Stimulate your cells to be energized. Stimulate your cells to produce growth factors, produce stem cells, produce more blood flow. With more blood flow, more tissue production, more stem cells, you're going to heal faster. Zirconia lasers are the ones I personally use. The FX635. We've got 3 red lasers right here. You can see those. Here's another one that I use, the GVL green and violet laser colors. Absolutely fantastic. We'll get into a little bit. The mitochondria of the cell are stimulated by red, green, and violet wavelengths. Another laser that we have is the Zerona Z8 body contouring laser. A whole nother concept with the fat cell, but this is 8 lasers, all of violet color as well, and just gives us another option of multiple lasers at once to target numerous areas and continue the fantastic benefits that we're seeing. So, laser photobiomodulation. Basically, that is when the light from the laser hits the cell and stimulates the cell. The science, the delicate aspect, the cytochrome C oxidase is excited on the cell. It is blocked by a nitric oxide. The light releases a nitric oxide, allows an oxygen molecule to come in and excite the cell. A stressed out cell, a damaged cell, an aged cell, traumatized cell, any part of aging, that stressed out cell has a nitric oxide blocking it there, and it's inhibiting the ATP production. It inhibits energy production of the cell. Basically, the laser is now going to energize the cell, allow it to do what it was meant to do. I tell patients all the time, and what we typically will see with the laser is patients will heal like a little kid. Kids heal super fast, and it's just amazing to see how fast they heal because their cells are revved up and ready to roll. This is essentially getting those cells back to that revved up and ready to roll, healthy cells to do what they should be doing. The main effect are anti-inflammation, bringing down the inflammation, reducing pain, reducing nerve sensitivity, increasing endorphins, increasing tissue repair. There's a difference between laser and red light. The big one, and there's MRI studies showing the depth of the laser, and this is one of the big ones, is The laser will go a 6 centimeter depth into the tissue, 6 centimeters, about that far into the tissues. Red light really is only skin deep. And in studies will show about 7 or 8 times more effectiveness of the laser than the red light. And again, athletes have been using this for a long time. Studies back to the 60s with Russian athletes. The Olympic Committee got involved. They had to see if this was enhancing performance. It was found to be okay because it's your own body's tissue. They found increased flexibility just by using the laser alone in a hamstring study, and more flexibility was there just by using the laser. So you can see the athletic benefit, and many athletes are using this for athletic performance. FDA approved for plantar fasciitis, low back pain, general musculoskeletal pain. So for most everything we do and use it for, approved and ready to go. And you've got all the studies, but I'm here to say we see it every day. The improvement in the overall tissue, reduction in pain, and just flat out speed of healing. Another study shows stem cells, and again, within a few hours, stem cell increased by 4 times, macrophages increased by 8 times. Basically, again, that photobiomodulation, the laser stimulating the cells, stimulating other cell recruitment is the nice cascade effect of the laser. Another interesting finding is that the CDC has now listed laser therapy as an alternative to narcotic pain medication. So I thought that was a fantastic recognition. In regards to plantar fasciitis treatment, we have the inflammation and pain and the need for healing, and the laser hits all of those avenues. The big study on lasers was 10-month average for plantar fasciitis to recover from. With the laser use, 4 to 6 weeks. Not 10 months, 4 to 6 weeks. Huge difference, and forget the study, we see it here in the office where it used to be months of treatment for plantar fasciitis. We are now seeing weeks of treatment with plantar fasciitis. Again, it's not just laser by itself. You need to do all of the treatments, but as far as stimulating the cells and putting your body in the best chance to improve, your best chance to heal the fastest is with excited, activated cells doing what they were meant to do. That's the best way to heal. If someone is advertising a red light, be sure to look at the references. Look at the studies that are being done. A lot of them are quoting the laser studies, and it's not truly a red light study. It's actually a laser study. So look closely at your research and that you're getting the right product and the right reasoning behind that. And any artificial intelligence searches on the computer you do, very dangerous, because you've got to differentiate and ask the right question to get the right answer. You're best off speaking to your doctor and getting the straight answer about what your questions may be and what the research actually will show. And hopefully I'm educating you on that. So now we're going to talk about advanced wound healing. So this is the new technology, and yes, it is fantastic, and I think this will become more mainstream year after year as the amazing results that we're seeing. The product that I use is Clarix Flow. It is amniotic membrane and umbilical cord tissue, of course sterilized into crystals, reconstituted, and to be injected. This produces a concentrated amount of growth factors and cytokines. I know that's a mouthful, right? But what it is basically is this baby tissue which stimulates this tremendous response of anti-inflammatory and tissue repair. And this was discovered with intrauterine surgeries that had these amazing results of immediate reduced pain, inflammation, no scarring, rapid healing, and on was, hey, how can we utilize this tissue in a normal clinical setting. And it is what we see. We see massive improvement and reduction in pain and stimulated healing. The cytokines are messengers that are stimulating and sending signals for reduction in inflammation. And the growth factors are stimulating tissue repair and stem cells to come down and heal. So in a difficult case where you need that additional stimulation in the area for pain reduction and tissue repair, this is the ideal product for that. So in a difficult case or one you just want to speed up healing, absolutely, this is the route to look at.
Stretching for plantar fasciitis. Well, we're really going to call it stretching and massaging, and we're going to get a little bit of detail about, can you really stretch the plantar fascia? So first, we're going to use the term several times, dorsiflexion and plantar flexion. So dorsiflexion up with the foot, plantar flexion down. Of course, your Achilles tendon here, your plantar fascia on the bottom. So any dorsiflexion stretch, you're going to pull the Achilles to stretch, you're going to pull the fascia, and by way of the heel bone, they have a loose connection. Studies have been done showing some small fibers in between the two, but more so a mechanical connection between the Achilles and the fascia. So when you stretch one or the other, it helps the other. A little side note in there is, if you are ambulating, walking, and you need more dorsiflexion this direction, the foot will pronate and help to unlock the foot to gain more dorsiflexion. So the more arch support you have, the more flexibility you have. It helps each other in both events. So stretching the Achilles, stretching the fascia, both. When I say massage, and we'll put up a picture of a massage gun, and the massage gun is going to basically, exactly what it sounds like. It's going to pound the tissue. It's a deep tissue massage, but a physical one. The stronger the pounds per square inch, the stronger the device. You can do that through the Achilles, through the calf, through the fascia. You may want to start on a lighter setting for those. But what that's going to do is break up some of the adhesions and make some of your stretching easier. When it comes to adhesions, that's what it's going to be all about. Right here, we'll show a picture of the plantar fascia on the screen here. And you can see the plantar fascia is fibrous. There is not really a big muscle or tendon. It's just fascia. So think of the straw broom effect, where you're not really going to stretch the fascia. You're going to break up the adhesions around it. There's a lot of attachments and a lot of adhesions throughout the fascia. And if I get my pro athletes, pro dancers, runners, there's a lot of scar tissue throughout the plantar fascia. And a lot of what we're doing is breaking up those adhesions so it can become more flexible. So that first step in the morning, there is a little bit of give to the tissue rather than just tight scar tissue throughout that area. So rolling a can, and you'll see this diagram here of the stretching exercises, and we'll run through those real quick. When I say can rolling, it can be a can, a PVC pipe, a rolling pin, any round device can be rolled. I'm not a big fan of a ball specifically. A ball tends to take path of least resistance. And with a can, everybody has a can in their cabinet, so you can say, hey, grab a soup can of different sizes. Different sizes work for different arches. So try that rolling across. And what you're essentially doing, again, is a deep tissue massage and rolling across the plantar fascia. A lot of patients will say, well, what's the best stretch? Well, it's the one you're going to do a lot of. Let's start with that. We need to have stretching all day long. So if there's one you really like, do more of it. But I really would like all of the stretches, whenever you can, to hit the different angles of the muscle. Speaking of angles, your calf, made of your gastroc and your soleus, are two different muscle groups. The gastroc attaches above the knee, the soleus below the knee. So when you're doing some of these stretching exercises, you can bend the knee and hold it straight. Straight leg, bent leg, if you're pulling back, bend the knee for one, straight leg for another. It'll make sense in the diagrams, but you're basically stretching either the gastroc or the soleus, and you're isolating those in those stretches. Big principles of stretching, and I'll give yoga credit for this one, is what I don't want you to do is say, oh, Dr. Magma, I gotta go stretch. 1, 2, 3, 4, 5, 6. You're pulling on your muscle. You're not really stretching. So what I'd like you to do is throw that band, that belt, that bathroom belt on your sheet in your bed before you even wake up, and pull the foot back. Take a big deep breath, fully relax, pull further. Now hold that stretch. That's where you really, really feel that deep stretch, that deep hold in there, and you can gain some flexibility. So obviously you're going to do that, then you're going to bend the leg, you're going to do the opposite side. All of these stretches are necessary to accomplish the fascia and Achilles stretching both. So that being said, hanging off the step, that's another one of my favorites. Walking in your house, hang off the step every single time. Once you get these habits, the stretching doesn't become a chore. And I think that's the key to discussing with the patients of when you walk in the house, you stretch here. When you brush your teeth, you put your foot up against the edge. Before you get in the car, you put your foot up against the tire. If you're at work and you can put your foot up against the leg of the chair. So it's this, at the end of the day, you think back, wow, about 30, 40 times I did stretches today, but it becomes mindless. This is going to be a process. It's not going to stretch out overnight. It didn't get tight overnight. So it's going to be a long process of stretching. And once that habit is there, that's when the tissue will soften. That's when you're not creating these micro tears every time you stand up, every time you try to take an extra step and walk. Yes, it still needs the support and all of the other treatments we're talking about, but the stretching is the key for treating now and longevity of this. And when you can gain more dorsiflexion of the foot, that's a better predictor of, hey, am I going to get this back in a month, in 2? And do I have to do this stuff forever? Now, maybe not 30 times a day, but you transition to that daily routine of a couple stretches here and there. And I always tell the patients where I will do the stretch on the edge of a chair, this one here, in the office, and I'll put my foot up and stretch just like this. And I tell them I'm demonstrating for them, and I'm really doing it for myself. If I went running this morning or whatever the case may be, it's a good stretch. You feel the pull, but the best thing is it's first thing in the morning, you're doing a stretch, you check in with yourself and you're seeing how tight am I, okay? Sorry, I have to do the other side. And it tells you how much more you need to do. So the sooner you stretch, the more you can feel where do you stand for the day, and then go through that process of repetitive stretching. If you can add the massage gun and the stretching, even better, because what you're really trying to do is loosen up the tissue, massage, break up scar tissue, gain flexibility. But again, as with the fascia, it's more fascia mobility than a flat out stretching the fascia because it's not overly very flexible, but full of scar tissue and adhesions.
Physical therapy for plantar fasciitis. Now you can send someone out to physical therapy department, of course, to do physical therapy. We do our own office/home physical therapy. Of course, the stretching, and we'll review all the stretching and mobility to increase the range of motion of the foot and ankle. But when we talk stretching, we really should use the phrase increasing tissue mobility, because it's not just pull and stretch. We have to loosen up, break up scar tissue to gain the mobility. So a massage gun, excellent home activity, a foam roller, a lot of, like for runners, you'll find a lot of these devices on some of the running sites, but massage gun, foam roller, any even handheld type of massagers through the calf, through the fascia, all extremely helpful. Office-based therapies, ultrasound therapy, that's going to use some deep tissue massage through ultrasonic waves. as a way to have a deep tissue massage. That can be done in the office with a little conductivity gel and some electrodes with interferential therapy. A lot of patients say, oh, I have one of those at home. They say, I have a TENS unit. And the difference there is that's electrical nerve stimulation, and that's sort of just a little buzz blocking pain, where an interferential unit, when you turn it up, the muscles are going to jump. You're pumping blood through those tissues. You're activating those tissues and reducing pain, inflammation, and stimulating the tissue in the area. We'll actually run the interferential at the same time as the laser to have an added effect with that. So think of the physical therapy as massage, tissue mobility, and stretching through both electrical, physical, sound wave, every aspect possible. When it says, oh, what one thing should I do? It's really a big group effort when it comes to physical therapy. Again, in office, in home, in a therapy department, all of these things are necessary and not just one. All right, low dye taping of the foot with athletic tape. Want to keep the foot at a neutral 90 degrees. He's doing a great job of that. Want to measure behind the first and fifth metatarsal heads. That. Two pieces of that ready to go. Initial two straps going on this way. Like that. Little plantar affects the metatarsal there. Always rubbing the tape in place. And plantar flex the metatarsal. Rub that in place. Just like that. I would say if the patient's bouncing, you're putting it on tight enough. Next are the cross pieces here. If you're not strong enough or can't rip the tape, you can cut these with a scissor, again behind the metatarsal heads. Here, load the foot, pressure here and across. No wrinkles. Pressure across, tape, no wrinkles. This larger tape can be used for ease of time. There we go. One more to finish off the edges. There we go. That is the technical low dye taping. Now, one variant that we add to this, relax the foot down a little bit, is we'll put a wrap of elastoplast around this, and this gives one little bit of extra support through the arch, a little tight there, and then just lay it across the top with a little gauze pad underneath. That's just going to help the edges of the tape stay in place better and add a little bit of support. That is your low dye taping with no wrinkles. All right, a low dye taping using kinesio tape. Again, foot at neutral, right there, held, good job. And I'm going to have no creases in the foot, like this. The tape can be put on 100% tension on the bottom, no wrinkles, and then laid lightly on the edges. Otherwise, these edges will peel away. Having the tape pre-cut helps, makes things a little faster for you. So again, tight, no wrinkles, laid on, laid on. One to go around behind the metatarsal heads.
This can be at a pretty good near full tension to there, and then laid down the rest of the way. Always rubbed in. Rubbing this tape will heat up the glue. And the final one around the foot, I'm going to put on here again, tight for support, and then laid across the top. We don't want to pinch the top of the foot, and then laid in for the last little bit. There's another version of the low-dye tape. So we're going to talk about injections, a steroid injection. A lot of people might call it a cortisone injection. A lot of different names for it, but basically a steroid mixture with a lidocaine or marcaine, some level of anesthetic that gives a numbing effect for a few hours or several hours, where lidocaine for maybe 1 hour of some numbness in the heel and relief of pain, or marcaine up to 12 hours. I prefer marcaine to give that lasting effect, and then the steroid taking its effect after that. It can be a little more painful in the injection phase and takes about 15 minutes to kick in, as opposed to lidocaine, a little less pain with the injection and immediate relief. So those are the two different anesthetic options to add or mix with the steroid. The steroid, there can be long-acting and short-acting steroids, whether it's crystalline or more liquid form, and that's a whole nother section of choosing the right type of steroid. I want to talk about the concept of why and how the injection is done. One more little tidbit on that, of the longer acting crystalline type steroid, that's gonna take about 2 weeks to fully dissolve, and the patient say, hey, how long is this shot gonna last? That's the most common question we get. And basically say it's gonna remove your inflammation. It's gonna shrink the inflammation down, and it's gonna last until you create inflammation again, until you create micro tearing, until you create that overload of the fascia or at the heel again. So it's not so much how long the crystals last, how much the product lasts. Think of it as a reset. It's going to bring the inflammation down, bring the pain level down. That allows the patient to then begin some of the stretching, begin some of the cannuling. They may just be in too much pain to even think about that. So it's a good adjunct to the treatment. It's not a just here's your shot. I've seen many doctors, they just inject, and they don't really have a treatment plan outside of that. I try not to inject unless the patient is, 8, 9, 10 out of 10 pain, distinct. When you touch right in this space and there is obvious swelling and sharp pain, focal right in that space, they need a shot. And most of the patients that are in that much pain are saying, yes, I would like an injection. And someone who wants to be injected into something that painful knows how much pain they have, and I think they get the best benefit because there is that much inflammation, and it really does need the steroid to really reduce that inflammation. And I would think of the steroid as an inflammation reduction and pain reduction to facilitate the rest of the treatment. But be sure to tape the foot, the low-dye taping of the foot, support it, have them rest a little bit after the shot, and let the shot really take effect. Also, a lot of different studies and things looking at steroid injections weakening the tissue, and there's merit to that. I think it's very safe if it's injected in the correct spot and it's on a limited basis. Multiple injections or injecting into a tendon, always very dangerous. So if you can keep it very limited to those cases, that is going to give you the most benefit, or allow the patient to begin a treatment program, and with some caution and proper support, I think it's absolutely something that you can add to the treatment protocol. Second or third injections, I rarely ever do, but if someone has the proper shoe, the arch support, they're doing everything right, and they just maybe overdid it and they have a new flare-up, or I don't see them a while, they have a new flare-up, it can be added as an adjunct, but it's more of, okay, show me the whole list of your treatment. Are you doing everything you should? And it's just really inflamed right here, okay, then a shot's going to have a lot of benefit.
not just as a quick fix so I can skip those other steps. That's not really the way it should be. We have a preloaded syringe, and you'll see the steroid just settle to the bottom as the white product there, and then anesthesia up here, the Marcaine for the rest of that. These crystals can get clogged in the needle. Be careful of that. It's a little bit thicker here, and you want to, if you do preload a syringe, you want to keep it held vertical, or if someone draws it up, make sure it's not down this way until you make that injection, so you don't clog up the needle. But those are the principles behind it as to why you would want to give the injection. And the place of the injection would be basically from the medial side. I've heard of people going from the bottom. That just seems like cruel and unusual punishment. You can achieve absolutely everything that you want from the medial side, and there's a little pocket of space right as you inject where the fascia extends out from. And there's usually, if they're that swollen and they have some level of bursitis in there, it'll fit right in that space and easily flow in, and you know you're in the correct space. You do not want to be down deep in the fat pad, because also a steroid can weaken a fat pad as well. You don't want to be poking holes in the fascia by virtue of giving them a surgery. And if it feels too difficult to push in, you're probably in the wrong spot. That's the take-home message on an injection. It should go in, inject very easily or smoothly into there. You may have to move or change the position a little bit, but make sure it goes in smoothly, and you know that it's going to work well. Another time that I will inject on those very rare cases of if there's a lot of scar tissue, you got this with a lot of runners, athletes, professional dancers that have a ton of scar tissue in here, and by virtue of the injection, the steroid can break up some of the scar tissue, and also just the volume of fluid going in can help break up some of the scar tissue there. And that is when, in some of those cases where there can be that rare case of a nerve entrapment, that can help break up some of the scar tissue that was entrapping the nerve, as one of those rare variants of heel pain that's not quite plantar fasciitis. And no one said it can't be both. So that's another a good tool of what the steroid injection can be used for. Some ice afterwards on the area, and certainly some rest as well. Surgery for plantar fasciitis. You don't need it. That's my blanket statement. You don't need it. Usually if someone wants surgery or talking about surgery, they have not exhausted all of the treatment options, the maximum support, the maximum stretching, the maximum can rolling to break up all the adhesions of the plantar fascia, or the diagnosis is wrong. Maybe there's an entrapped nerve, maybe there's some bone involvement, and other diagnostic tests need to be done. So to go back, surgery was done for plantar fasciitis the 60s, 70s, 80s, and they cut the spur out as well. They relieved their pain, but what they found later was the arch continued to fall, as the plantar fascia is a major support structure of your foot. So don't cut the major support structure of your foot at all. And even when I started residency in 1998, we were still doing some plantar fasciitis surgeries at that time, but even during the course of that, the amount of the fascia cut was from full to half to a quarter to, it got to the point of cut only the little tight band that was there, because we were seeing the follow-up that the arches were following, and that mid-tarsal arthritis was forming as an after effect. So the answer is, don't have surgery. Now, look closer at what may be happening. Now, you could have surgery to go in, release some of the adhesions if there is a nerve entrapment at the heel, but I also prefer to do an alcohol shot or several alcohol shots to kill that nerve prior to a surgery, or more cortisone shots to break up some scar tissue and adhesions. I would keep surgery as a last resort, but I would more so take it as a just don't do surgery, because everyone can get better. It's a statement of do more, look harder, And if there absolutely was the worst case in the world and you absolutely exhausted everything, only that minute, tight medial band, and you could basically almost do a stab incision and just release barely the tight fibers of the extreme medial band, if that was the last resort for surgery. But in every case I've seen, there was more that could be done with surgery. So the answer is don't do it, but use it as a flag of, okay, if we're at surgery, let's go hardcore. Give me 1 month of be perfect, arch support, therapy, stretching, and really document it. And weight loss. It might require 30, 40, 50-pound weight loss to take the stress off the fascia. And if the shortcut is cutting the fascia and haven't lost the weight, well, now you just lost support for someone who is overweight, and that may not be the answer as well.
So with regard to plantar fascia and surgery, this would be the medial band here. The medial band is usually the tightest of the bands, and where most of the pain emanates from here at the heel is because this band is tight. Now, the entire fascia spans this entire distance and important to stretch out the whole area. But when I'm talking about surgery, if there was just one little tight fiber right along this edge and nothing else worked, you could release one little tight fiber, but in the big picture, you have lost part of the support structure of the foot. And when looking down here and seeing the support of the fascia here, there could add to the eventual collapse of the arch by losing support on the bottom. So if all this tissue around, the scar tissue, the fascia, all of this can be loosened up, surgery is not necessary. If it had to have it, I would keep it absolutely minimal at just whatever little tight fiber was there relieving pain, leaving well up to 90+% of the remaining fascia intact. But my first focus would be not to do surgery.
Okay, a final wrap-up of plantar fasciitis. Now, that's hard to do, is to summarize plantar fasciitis, but the take-home message is, number one, listen to the patient. Listen to what the patient has to say. That's where the diagnosis lies. And number one, get the correct diagnosis. Is this truly plantar fasciitis? Is there something completely different happening? So that's step one, is absolutely get the right diagnosis and focus on the patient, what they're saying. Look at the foot, look at the footwear. Does it fit that standard plantar fasciitis mold? If not, additional testing. Also look at the ultrasound, order an MRI. Is this truly plantar fasciitis? If it is, then are you doing everything you can do? Is the patient doing everything they can do? And usually that is step by step throughout the day. Can they do more? Can they have better arch support, better shoes, better stretching, better massage? What are they doing at home? That's a big one that's usually missed. Are they barefoot at home and just neglect all those things they should have been doing at that time? If all of these are being done, they're doing everything, and then some weight loss to go with it. They're taking the load off of their feet. And look at that. What's the weight loss? What's the activity level? How much are they pounding on that fascia? After all of those aspects, then let's look at advanced healing techniques. Can we stimulate it more with the laser? Can we stimulate it more with the amnio injections? What other advanced wound healing or tissue healing techniques can we add to the mix? There's certainly plenty of things that can be done, but it's a stepwise approach. And the key, not everyone is the same. Yes, the vast majority fall into that main bucket, but the outliers are there. And just ask the questions, see what's needed. And so exciting with the advanced healing techniques, with the lasers, the amnios, and all these other treatments, that we're now seeing weeks of treatment and not months of treatment. And I think that's the most exciting part of where we're headed with this. So go get them with that plantar fasciitis.